Welcome, everyone. Thanks for joining us. And Dr. Moralia, thank you for joining us tonight.
Oh, yeah, my pleasure. We'll have a good time.
All right, we like to be prompt, so we will get started. I will go over a few housekeeping items, and then I will kick it over to Dr. Moralia, the main reason all of you tonight. Thank you, everyone, for joining our session tonight on techniques and strategies for long-term success with clear aligners, presented to you by Dr. Ben Moralia. I'm Kyle Bivenauer, and I'm part of the clinical education team here at Candid Pro. And we're very excited that you've decided to spend your evening with us. So like I said, I have a few just quick housekeeping items to cover before I'll kick it over to Dr. Moralia. The first one is that this session is being recorded and an email will be sent following the conclusion of the webinar with a link to the recording. So if there's anything you want to go back and view, you'll have access to do that. And then at the end of the session, there'll be two spots in the presentation where there's a QR code, and we will call that out during the presentation. That QR code will link you to a quiz. That is the quiz that you'll need to take to receive your CE credit, and there will be one CE credit earned for tonight's webinar. Questions we will take at the end. So if you have any questions throughout the course of the presentation, feel free to drop them in the Q&A function in the webinar, and we will answer those once all the content has been covered. So with that, Dr. Moralia, I will send it over to you.
All right. Yeah. Thank you, Kyle, and welcome, everybody. We'll have a little bit of fun this evening. The title is Clear Aligners for General Dentists.
All right. Welcome, everyone. We'll give everyone just about a minute to get into the call, get settled in before we start our presentation this evening. So welcome, everyone. Thanks for joining us. And Dr. Moralia, thank you for joining us tonight.
Oh, yeah, my pleasure. We'll have a good time.
All right, we like to be prompt, so we will get started. I will go over a few housekeeping items, and then I will kick it over to Dr. Moralia, the main reason all of you tonight. Thank you, everyone, for joining our session tonight on techniques and strategies for long-term success with clear aligners, presented to you by Dr. Ben Moralia. I'm Kyle Bivenauer, and I'm part of the clinical education team here at Candid Pro. And we're very excited that you've decided to spend your evening with us. So like I said, I have a few just quick housekeeping items to cover before I'll kick it over to Dr. Moralia. The first one is that this session is being recorded and an email will be sent following the conclusion of the webinar with a link to the recording. So if there's anything you want to go back and view, you'll have access to do that. And then at the end of the session, there'll be two spots in the presentation where there's a QR code, and we will call that out during the presentation. That QR code will link you to a quiz. That is the quiz that you'll need to take to receive your CE credit, and there will be one CE credit earned for tonight's webinar. Questions we will take at the end. So if you have any questions throughout the course of the presentation, feel free to drop them in the Q&A function in the webinar, and we will answer those once all the content has been covered. So with that, Dr. Moralia, I will send it over to you.
All right. Yeah. Thank you, Kyle, and welcome, everybody. We'll have a little bit of fun this evening. The title is Clear Aligners for General Dentists, Techniques and Strategies for Long-Term Success. So I'm going to walk you through what are best practices, basically, things that I've been doing for on a regular basis with the Candid aligners now. And my bio is 30 years in dentistry. It's my 31st, 20 years doing the aligners, and so the last 4 with Candid. So I am the Vice President of Clinical Education at Candid. I'm not receiving an honorarium for this presentation. So there you have the disclosure. The agenda, we're going to talk about screening so we can identify and diagnose, patient education, some case reviews, and then the Candid Pro Clear Aligner system. Once we get through the beginning section, then we can conclude the CE portion, and I can talk more about Candid Pro specifically and give you some of the differences between competitors and how we believe we're positioned to be the best choice today for you. All right. And then, of course, a lot about the remote monitoring. We'll talk about that too, how we handle the reduction in chair time for you, increase your profitability. This whole thing geared towards having long-term success. We'd like to just remind you of a few things. Consider your journey. I want you to think about something like this dynamic where you might have treated a patient with 23 aligners and then get 18 additional to finish. And a lot of you are probably in the clear aligner space already, where you're treating patients and maybe you're using a competitor, or maybe you've tried Candid yourself. But if you're treating a case with, let's say, 23 aligners, but then you submit for a refinement or additional aligners, whatever you want to call the second set, and you get a number similar to the first number, something went wrong. So I want you to just think about these things and see if these are familiar to anybody out there, and just think it over while we're talking about the rest of the presentation. How about the opposite? What if you treated a patient with 18 aligners and then got more in the second round? So I'm just using 18 and 23, fun numbers to play with, but any number of aligners, but then the second round, you get more than the first round. That could be trouble. What if you've done 2, 3, or 4 rounds already of aligners and you're still not finished? But there's something worse that could happen. You've done 2, 3, 4 rounds, and you might be thinking that the patient has a worse bite than when you started. And so if you've been involved with 2, 3, or 4 rounds of aligners and the bite's a little bit worse than the beginning, this is trouble. Things are going sideways on you. Using more attachments over time, but experiencing less clinical satisfaction. So those of you who are in the aligner game a significant amount of time might recognize there was a time where attachments were few, and then they grew and we're getting more and more over time. And if you're new to the aligner game, you're just then experiencing now getting a lot of attachments placed on the teeth, and putting a lot of attachments on and taking them off isn't that fun. But if you're in the game for a while, you might notice that I'm using more attachments over time, but I don't think I'm treating these cases any faster or any better than before. And maybe you have the other opinion of, I'm putting more attachments than ever on, and I'm not really getting any better results. I might be even getting worse results. So something to consider. Starting with 12 or more attachments, but then getting more with the additional aligners. So round 1, you put a dozen attachments in the patient. You do a bunch of aligners. For round 2, when you send in to make a new treatment plan, you get more attachments in the next treatment plan. So that's strange, right? When you wrap your head around that one, wait, I have attachments on teeth that didn't have them in the first round. How did I not need them in the first round, then I need them in the second round? So that is a whole nother interesting dynamic, that something might have gone sideways. Are you and your patients enjoying the molar attachments? Now, if you're in this game for a long time, you realize there were no molar attachments for the first decade of the clear aligner, maybe even 15 years. The first 10 to 15 years of aligner treatment, there was no molar attachment involved. And all of a sudden they popped into the mix. And meanwhile, are you having better results with them or not? Having a posterior open bite is trouble, and getting a posterior open bite during or after the first set of aligners, if this has been your experience, something went sideways. Use a set of aligners designed to correct a posterior open bite, but then see it remain or get worse. So if you get a posterior open bite, it's very likely you will send in a new set of records and say, please make me a treatment plan that will correct the posterior open bite my patient has. And then the patient wears those aligners, and you might recognize this experience of seeing the same posterior open bite after those aligners, or it could actually be a little bit worse after round 2. Have patients complain about TMJ symptoms during or after alignment. Patients who have no history of TMJ symptoms, head and neck pain, jaw joint pain, but all of a sudden into the aligner treatment have it. So this one's a very specific one. It's a retractive orthodontic technique. If you're retracting the teeth and getting TMD symptoms, you need to stop and go the other direction. So we're not trying to have patients get TMD symptoms. We're actually trying to do the opposite. Take a patient who has TMD symptoms and give them a beautiful expansion technique, and reduce or eliminate the symptoms would be nice. But this is a little pitfall people get into when they have a retractive technique in their aligner treatment plans. Have you considered the chair time involved with this list? So any one or more of these things might have gone on in a case or two for you. And if you're thinking about, this seems familiar, I've had these experiences over time, the chair time gets to be tremendous with this list. The more you have to be involved with the case, and the more you have to put on and off attachments, and the more you have to play with the posterior open bite. If you were keeping track of this list, represents the things that make your clear aligner treatment, let's say, not profitable anymore. So the moment you get down any one of these roads and you're experiencing this, that case no longer becomes profitable. And over the stretch of time, the amount of hours you're spending compared to what you had to pay for a lab cost and subtracted it when you did all the math, you probably would have been more productive putting some sealants on a kid. So we want to consider our pathway and how we're going to avoid this list, because nobody really wants to be treating the case over and over time where we're losing money then to do it and we're still not getting a good outcome. So you think about this list, and you should be questioning whether your current aligner company and technique is still profitable. And I'll say fun, because clear aligners in the office should be fun and profitable. We would like to have both back. So we're going to get you through this, beginning with patient screening. So this is like a very compressed into a nutshell because we get an hour tonight, but it all begins with patient screening, and everything we're trying to set up for long-term success begins at the starting point of the patient being screened by the hygienist. And so for best practices, this conversation begins early, and we do it in the patient with the patient in the hygiene chair because that's where they have the most amount of time and the best relationships. And we already know with the people walking into our practice that 3/4 of them could benefit from aligner therapy based on an AAO little research project that you have this quote in their study that 75% of adult patients could benefit from clear aligners. Meanwhile, if you just think about adults coming into your hygiene chair, are 1 out of 4 of your adults coming in with perfectly straight teeth and a nice bite? I don't see it being that high. So in my world, I'll tell you it's more like 95% of patients could benefit from clear aligners. And maybe even 5 out of 100 is generous. 5 out of 100 adults come in and they have perfectly straight teeth with a nice bite. It's a low number, adults that have really nice teeth and a nice bite. So we have a lot of patients to talk to and benefit. But in the hygiene chair, when they have those numbers in their favor, all of a sudden you have this position where a hygienist will see 8 patients in a day, which is a 4-day week is 32. And then 75% of that's 24. And that's in a week. So there are 96 patients coming through a hygiene chair, one single hygiene chair in a month that you could talk to about and have this conversation about improving their bite and making a healthy choice. And then how we go about doing it is important. So when we talk about screening, there is a little malocclusion brochure, which has some items on there, but I want to talk about the common things that we all see, and these are readily visible by the hygienist and can be incorporated into conversations right away. Misaligned, crowded front teeth. The simple thing is misaligned teeth. It's very easy to see crowded teeth. It's easy to see recession. It turns out if you're watching your patients, most of them have recession, and it's very rare to find an adult that has no recession anywhere. So just screening for does my patient have one area of recession or more? And then of course we have something to talk about. Does my patient have abfractions, one or more? And so you could look at it one of 2 ways. You're either looking for the abfractions or you're looking for an adult that doesn't have any. And so as soon as you start recognizing that, hey, a lot of adults have some recession and abfraction and crowded teeth, okay, this is the majority of people having this chipping or wearing of the incisal edges or the cusp tips. So this undue wear, maybe there's bruxing going on, maybe there's clenching going on. Things like this are occurring, or maybe they're just chipping and wearing things. And in the absence of clenching and bruxing, the teeth have such poor occlusal contacts, the trauma is there and they're wearing stuff out ahead of time. This also is a nice thing we can screen for, something anybody can see. And the last but not least is the tooth sensitivity. Usually patients coming in for their hygiene visit will readily share, oh, this is sensitive, that's sensitive, don't blow the air here, don't touch this one with the metal, watch out with the cold water. Like they're talking about all this tooth sensitivity. Meanwhile, when the hygienist has the best relationship most amount of time, these are things they can see. And when you see these, you're screening. And when you screen for these things, it starts the conversation. And as you're having the conversation, leading to photos and a scan is also nice too, because you're starting to pull, records. But as soon as you start having a conversation, this becomes a handoff, because the moment you start talking about the things you're noticing and why they might be there and how your bite is coming together in a way that delivers trauma to the teeth, you have a chance to hand it off to the doctor. So the hygienist does the screening. They begin talking to the patient about what they're seeing, which is this list of things that's easy to see. And certainly then when we're handing it off to the doctor, it becomes about talking about a screening transitioning to a diagnosis. So these are just some common examples of like everyday hygiene patients in any dental practice. You could find this type of mouth anywhere. These are the kinds of malocclusions that show up in hygiene chairs all over, getting their teeth cleaned on a regular basis. And meanwhile, these are all traumatic occlusions. These are all mouths that have lists of symptoms going on that can be screened for and or talked about, because these mouths are going to deteriorate ahead of schedule as opposed to aging appropriately. And so we're going to build this out as a nice way to approach patients, from step 1 being screening, step 2 being diagnosing. So the doctor's going to come in for the handoff because the doctor checks the patient, just like you come in for the regular recall visit and you might check the x-rays and do your cavity check and your perio check and all that stuff. When we're doing the occlusal check, because now part of it is Mrs. Smith is here. We were pointing out some of the areas of recession and the grooves on the side of the teeth that we call abfractions, but also we learned today about sensitivity. Certain teeth are sensitive to cold. We're going through this list of things we're finding, and we're thinking that her teeth are not coming together as good as they should. So I did Let Mrs. Smith know I was going to share that with you for you to take a better look. And now the doctor's got to make a diagnosis. So you start looking at the difference between symptoms and root cause. So the teeth are a symptom. So if you see crowded teeth, that's your symptom. The cause is an underdeveloped arch, so improper arch form. So an improper arch form is something that you can diagnose. It'll be the difference like this, a V shape or an omega shape. These are very common. You're going to notice there's a lot of crowded front teeth that show up with a V or an omega shaped arch. This is not where our teeth belong. It's not the shape we're supposed to have. Arches that are V or omega, you get malocclusion because you're not going to have these teeth come together appropriately. So now we know when these teeth connect, they're really colliding, not connecting. And now you've got teeth that are under strain. It should be no surprise this patient will have, all the different things and all the dentistry in here to show for it that over time these things deteriorate. Now, proper arch forms a beautiful dome. That's what we're supposed to look like. So when we have this ideal, like broad, wide U-shaped arch, then you have the opportunity for the teeth to actually connect appropriately. So this type of arch form has the chance to have a really good bite, and a bite that we would call protective and stable. Whereas the V and omega shape are going to come together and land in occlusal trauma and give us deterioration over time. Now, arch width is number 2. When we're thinking about cause of our crowded teeth and bad bites, the improper arch width is number 2, and that's measurable. So now we do start measuring between teeth 3 and 14. We're going to be measuring right at the gum line, the shortest distance between 3 and 14, like where the pointers are. And we want that distance because there was a lot of nice research that showed the healthy, stable occlusions developing naturally have a 35 to 39 millimeter transverse measurement. So the transverse measurement is the shortest distance between 3 and 14. You can use a Bowley gauge. You get your Bowley gauge out, measure. It's a slide rule. You put it in there, you slide it open, you see what you got, right? Or if you can't find the Bowley gauge, then you use a cotton roll. And so taking a cotton roll and placing it one tooth going across, you can start to see, oh yeah, my cotton roll doesn't fit. Now the cotton roll you're going to put in there because it measures 37 millimeters. So your cotton rolls measure 37 and you go tuck it in. With good occlusions, it should fit between the molars there, but it won't. You're going to find a lot of crowded, narrow jaws with crowded front teeth, come narrowness, and next thing you know, hey, my cotton roll doesn't fit. Take it back out, trim it a little bit. Once the cotton roll fits between 3 and 14, after a couple of trims, you can measure it right on the ruler on the counter and say, oh my goodness, my patient is 32, or my patient is 31, or my patient's 34. You'll get a number. We're measuring this because we know from the early growth and development research that when the kids who grew up without needing orthodontics, who ended up having nice teeth develop into good bites, they had a very consistent measurement. They were 35 to 39 millimeters between 3 and 14. So we're looking for that range to be at least a guide for having really good arch form and width, and it's measurable. So what a nice tool to have. If you're looking here, you're going to see just a quick before and after of a nice case that was treated with certain credentials. Number 1, no attachments. This is done with no attachments. Number 2, and not only is it done with no attachments, it's done with no IPR. So no IPR, no attachments, but we're looking at the patient who has improper arch form at a narrow arch width, an arch width that is under 35 millimeters. And then after the Candid aligners, we have a beautiful arch form at an appropriate arch width. We're in the range of 35 to 39, so we get that patient above 35. So all of a sudden, that transfer from poor arch form and width to proper arch form and width gives you a chance to have a good occlusion. Left side of the screen, bad occlusion. That will deteriorate over time. Teeth, gum, and bone. On the right side, we have a beautiful occlusion as a result of that movement, and you can have then aging instead of deteriorating. So that's just a quick kind of before and after of solving for arch form and width. Now, there's a third one in here that we're using for our diagnostics, improper buccolingual inclination. So arch form, arch width, and inclination. These are very important things that lead you down the road of making a good diagnosis, because now you're diagnosing malocclusion and gives you a chance to treat the cause and work your way from malocclusion to beautiful occlusion or healthy occlusion. And so we're looking to get a hold of this buccolingual inclination. It's easy to see in a photograph because all the ways to describe it, but buccolingual is cheek and tongue, and inclination is lean. How are the back teeth inclined? So on the left side of the screen, the back teeth are more uprightly positioned. So when you have the lower and upper teeth in a more vertical position, they connect better and they deliver vertical load to each other. So proper buccolingual inclination is vertically placed teeth. Whereas on the right side of the screen, you're seeing the lower teeth leaning in. And when the lower teeth lean in, the upper teeth lean in. And what you end up with is this collapse. And that excessive lingual inclination is what you're looking at, is improper buccolingual inclination. Lower teeth leaning too far in, upper teeth leaning too far in. When you see crowded front teeth, you're bound to see lower excess lingual inclination and upper excess lingual inclination. So if we could solve these three things, get back the arch form, the arch width, and the inclination, you'll not only deliver well-aligned teeth, but you'll deliver a beautiful vertical load in your occlusion. And so when we look at this little pictorial, I found this in a textbook of occlusion. It was around 1971, one of the first references to traumatic occlusion or occlusal traumatism. Improper arch form with an inclination deliver destructive horizontal forces to the teeth, gum, and the bone. So if you have the horizontal loading of the teeth, that was called occlusal traumatism, horizontal or lateral force. If the teeth are upright and you can load them vertically, vertical or axial loading is healthy. So we would call that occlusal health. So the difference between occlusal trauma and occlusal health is usually the collapse of the posterior teeth. So while the front teeth are crowded, the big problem is the arch form with an inclination. So while we would love to have the front teeth straight, we just don't want to focus on the front teeth. We want to solve the entire malocclusion. All of this adds up to a pathway to have the long-term success, because you're looking for a really stable result that delivers a beautiful arch form with an inclination for good occlusion, not just straight front teeth. The shortcut is to do a lot of IPR in the front teeth and make them straight, but that doesn't solve the arch form width or inclination of the posterior teeth. So all of this adds up to, it's really the back teeth that are causing your problems, not the front teeth. So now patient education. So let's say we've had the hygienist doing the screening, the doctor finishing the diagnosis and taking these little bit of records and measurements and information. All of a sudden, someone's got to talk to this patient and educate them so they understand what we are seeing and then what are the options. So the pathway for educating a patient can begin with a simple icebreaker. Did you have braces as a teenager? So if you always find it weird to, how do I talk about aligners? Do I ask them, do they want aligners? Is there a family wedding coming up? Should we do something for your teeth? There's these weird ways to do it, but there's a nice, easy icebreaker. Just ask, did you have braces as a teenager? And the fantastic news is that it doesn't matter what the answer is, because the patient that says, I did have braces as a teenager, you get to follow with, how long did it take you to lose your retainer? Because you know they didn't wear it because the teeth are crowded again. If the patient says, I didn't have braces for a teenager, you can say, congratulations, lucky you. You didn't have to suffer for all those years with the braces and the rubber bands and the headgear and all the nasty stuff everybody else had. And meanwhile, you've got these teeth where they are. We should still talk about where they are, because you may still benefit from helping those teeth get where they need to be. Either way, you've got a nice, easy icebreaker, and it's part of the record. More often than not, the people are going to say, I did have them as a teenager, but I didn't wear my retainer well, so they shifted back. And that's okay. When you're teaching your patients or looking at stuff, we don't use a handheld mirror. The handheld mirror is difficult to see what's going on. You want a nice set of photos. So good practice would be take a nice set of photos and have a monitor you can display them on, and also take a nice scan, because if you can scan your patient, now you've got them in the scanner, and then you can pull it up there too. It's nice and easy to see stuff. Large screen, good photographs, and more often than not, your patient will say something like, ooh, are those my teeth? Because when you zoom in and you start catching stuff and they can see, oh, recession and abfraction, the grooves on the side, all the different things going on, the gums, how they might be pink in some places, but maybe red or puffy in others. So the gingivitis will show a little better. The plaque will show in a nice photograph. So you can start to show all of this stuff. And certainly you're going to talk to your patients with a pattern so that they can understand this. And it doesn't start with your teeth are crooked, you need aligners. It starts with identifying a problem, talking about your concerns, and then making a recommendation. So we'll fill this in. We begin with our problem, which is you've got crowded teeth and really a bad bite. Now, sometimes you can go with the deep bite, but you have to teach them what that is. So I don't necessarily use deep bite, but we're going to recognize for our own benefit is that we see a lot of crowded deep bites. So you're probably looking at crowded deep bites as the majority of the malocclusions out there. But in the end, what we have to have the patient understand is their problem is a bad bite. Okay, so again, we're talking to the patient. In a professional setting, we would just say malocclusion, but meanwhile, the patient has a bad bite. Now, with that bad bite, our concerns are the grooves on the side of your teeth, the recession of your gums, the wearing of your teeth, the chipping of your teeth. And for patients who have tooth sensitivity, you can just throw tooth sensitivity right on that list. These are things that most adults have because they have that crowded deep bite. So our concerns are that these things are ongoing problems and you are deteriorating. So as these are happening, we could fix all these things. Like we can fill in the grooves, we can give you gum grafts, we can fix your teeth over and over, because these things keep going as long as the bite is bad. So if you have a bad bite and there are concerns that are visible in the photos that are happening, the next thing is the recommendation. The recommendation, don't just jump right to, we need aligners. You slow it down and you say, what we recommend is to correct your bad bite to a good bite. There is a pathway to take your bad bite and make it a good bite. But in order to do that, we have to move your teeth. So since we need tooth movement, don't worry, we're not talking about braces. You do not have to have braces. We're going to talk about clear aligners. And using clear aligners, we can move your teeth where they belong and correct your bad bite to a good bite. Now, all of this talk of bad bite to good bite, this is easy, the problem, concern, recommendation. But now you do have to add one more puzzle piece. You have to teach your patient the difference between a good bite and a bad bite. You just can't say good bite and bad bite. We want to teach them. So the words we use that patients start to recognize very well are that a good bite is protective. And what will happen is your teeth, your gums, and your bones will age appropriately. So having a good bite means your teeth, your gums, and your bone will age appropriately. They will last a lifetime with good function, good comfort, and looking good. So you can say they will function for you, they will be comfortable for you, they will look good, or you can just use the words here. Now, small changes over long periods of time. A good bite changes slowly. So you get small changes over long periods of time. And what that equals is less dentistry, having a good bite. We consider this healthy. So since a good bite, the teeth connecting appropriately protects the teeth, the gum, and the bone, you have something that is healthy and stable. A good bite is desirable. But then we have to contrast it with a bad bite. So the good bite is protective, the bad bite is destructive. Your teeth, your gums, and your bone age prematurely. Your teeth, your gum, and your bone are deteriorating ahead of schedule. So nobody wants to age in the first place, but certainly nobody wants to deteriorate. That's even worse. So the one thing worse than aging is deteriorating. So you start talking about how when your bad bite is coming together, your teeth are beating each other up, they're beating the gums up, the bone is going to suffer underneath. You are aging prematurely here in the mouth. Your mouth is aging too rapidly. And if your mouth is aging too rapidly, it will require more dental procedures. I'm going to have to fix your teeth more often. The fancy word periodontist, periodontal procedures, that's the gum and the bone. You're going to require more of that. And the endo, that's our fancy word for root canal. So the bad bite delivers more root canal work, more gum work, and more tooth work over time. Why is that? Because the bad bite being destructive gives us bigger changes in short amounts of time. And when your teeth, your gum, and your bone change more rapidly, we have to fix them more often. So all of a sudden, we call this unhealthy. That's an unhealthy mouth that is aging too rapidly. So the moment you get a grasp of all this, and it just takes a few minutes, and in a few times doing it, it comes out and flows really smooth, your patients start paying attention that even though they're comfortable, they don't have pain right now, they feel okay, that doesn't mean your mouth is healthy. Their mouth is deteriorating ahead of schedule. Now, that gives us a chance to take a look at a couple of cases here. So when we look at these cases, we get to talk about a few different criteria. So here you're going to see before and after, top and bottom of the screen, and some of the criteria are on the left side of the screen. This is going to be 16 aligners. There's no IPR used. There are no attachments used, and this was done in 2 visits. So when we're looking at the before and after, I know we like to focus right away on those front teeth, and we can see, okay, that one tooth is squeezed out of the arch, and there's no room for it. So there's a little bit of crowding there. Of course, we like to jump right to the bottom of the screen and see it lined up in there. So you've already seen that it's fixed and it's straight. But I want you to rethink about what happened here. The teeth that had no room and all of a sudden are perfectly aligned, this was done in 16 aligners. That's 8 months' time without any IPR and without any attachments. So 2 visits is a start and a finish. There's no refinement. And more than just the teeth really getting lined up very well in that short amount of time is how the gum tissue remodels. So even though this is just a very mild case of a little bit of crowding, you didn't need any IPR. You didn't need the attachments. You could do this in 8 months and have not only a beautiful alignment of the teeth for beautiful occlusion, but when you do move the teeth where they belong, you start to get into a situation where the gums start to remodel. And this case here, in those 8 months, the gum tissue grows and migrates nicely with the teeth without doing any grafting. So there's no grafting here, there's no laser, there's no anything being done to this tissue. All of a sudden you have full remodeling of the gingival tissue. Just a simple, mild case. However, we look at this case because we've probably seen it treated 2 other ways. And the one natural way to do this would be just throw the IPR in there, because a lot of people in the clear aligner game have seen tons of IPR over the years. And yeah, you could put IPR all over this, but meanwhile, you're not addressing all of the teeth then. You're just cutting the front ones to fit that in. Meanwhile, to move these teeth, all we had to do was commit to moving all of them a little bit. So every tooth moves a little bit, and shifting the teeth a little bit all the way gives you all of this to line up. It basically is about widening the arch or expanding the arch. If we just make the teeth a little bit wider, upright the back teeth, you can see the difference, the lower teeth leaning towards the tongue versus upright. Now you've got more room in there for your tongue. That's always a benefit to any patient. And you've done this without IPR. So option number 2 would be, this could be done with IPR. Fair enough. You can do a bunch of IPR on the front teeth and get them straight. Option number 3, there's a fair chance, if you're in dentistry long enough, you've seen this patient treated with an extraction of that incisor. Just take one of the incisors out and line up the rest of the teeth. There's a little bit of crowding. You take one out, you line the rest up. Sure, that won't take less than 8 months either. So all of a sudden you have these options. Take a tooth out, do a bunch of IPR, mini extractions, or just move the teeth where they belong. And to do this in 16 aligners with no IPR and no attachments and 2 visits, pretty smooth. This is pretty smooth, and patients really appreciate that. So you have something mild going on right here. But let's take a look at one step further where we do a little bit more. Here comes a little bit more narrow. So a little bit more narrow where we start to see what we were talking about. Improper arch form, improper arch width. There's a little more crowding going on in the top and bottom teeth. The photograph on the bottom isn't wonderful, but you can still see where the level of crowding is there. So we have this setup on the left side where we have a little bit of a deeper bite. But look at the credentials, 16 aligners. That's again 8 months. There's no IPR being used here. There's no attachments used in this case, and it's 2 visits, a start and a finish. And we are going to talk about the monitoring when we get to the specifics. I just have to get through like the CE portion first. So I'll cover the monitoring towards the end. But what we're doing here is addressing not the anterior teeth, but the posterior teeth. Address the arch form, address the arch width, address the inclination. So of course you could see this omega-shaped arch converts into a beautiful dome shape. Correct the arch form. The width increases, so we get that patient from a sub 35 number to a above 35 number, which is nice. We talk about inclination in the middle photograph, because in the middle photograph is where you can see the lean, the back teeth from the canine back, they're leaning towards the tongue. On the right side, the back teeth are upright, the back teeth, you get your vertical load back. So if we could just upright the posterior teeth, you get your vertical load back. You've taken someone from occlusal trauma, horizontally loaded posterior teeth, to vertically loaded posterior teeth, giving you occlusal health. The lower teeth shows very nicely about the uprighting of the lower teeth. You've got the crowding goes away, the arch form is back, appropriate arch width, beautiful inclination. And next thing, one of the nice things that you see here is the deep bite disappear. And so in 16 aligners in 8 months, we don't expect to get this kind of intrusion. That's because we're not intruding the front teeth. We approach the deep bite a little differently. It comes from the uprighting of the posterior teeth. When you upright the posterior teeth, they touch sooner. And when you upright upper and lower posterior teeth and they touch sooner, the front teeth lose the deep bite. So you're basically restoring the proper VDO for the patient, or improving the VDO for the patient, because the patient who has a deep bite of the anterior teeth is posteriorly collapsed and closing too far. So we'd love to have that restored and not only give them beautiful vertical load of the teeth, but having that bite opened up a bit gives the tongue more space. So we get more space in the width and we get more space in the vertical. And when the tongue has more room, good things happen. So this is another nice, very simple, very straightforward case where it solves all of the malocclusion in a very short amount of time, 8 months without attachments and without IPR. Then it gets a little worse, a little bit more collapsed and crowding, a terrible arch form on the left side. And as you start to get more crowding, you recognize there's more posterior collapse. With more anterior crowding comes more posterior collapse, comes a deeper bite. And sure enough, we're looking here at a little bit longer case. It goes to 25 aligners, but the same credentials in that there's no IPR and no attachments used here. Without any attachments, with no IPR, it took 3 visits. So we would have 3 visits over 25 aligners, which is a year. So in a year, having 3 visits only, 3 times in your chair is very nice for reducing the chair time. Low chair time, higher profit. Beautiful tracking, which we'll get to when we talk about the specifics of the workups. And this is taking someone from improper arch form with an inclination all the way to beautiful arch form with and inclination. The arch form and the arch width can be seen in the upper and lower photos, but it's the middle photographs that you pick up the inclination. In the middle photograph, the lower teeth are leaning in, the upper teeth are leaning in, and then you start uprighting the back teeth. It solves the deep bite. You get your beautiful vertical load of the posterior teeth. And of course, when you're doing this beautiful expansion technique and uprighting all these teeth and delivering really nice alignment of the teeth, when you're moving teeth where they belong, you should expect the gingival tissues to remodel favorably. So you can see here from the lower picture how irregular the gingival tissue is. So with the crowding and the displacement of the teeth come different gingival heights. So we've got all kinds of gingival architecture here that is not normal or ideal. And yet at the end, without using any type of periodontal surgical procedures, there's no laser, there's no scalpel, nothing's been done to the tissue. This is just remodeling. Gingival, dentoalveolar and gingival remodeling over the 25 aligners is 12 months. And now you end up with really beautiful papilla, normal, almost ideal gingival architecture, as if those teeth erupted there on their own. Meanwhile, you have the leveling, beautiful leveling. Look at the posterior teeth inclination in the lower photograph from the leaning in to the fully upright. Now you get your vertically loaded posterior teeth. You take a lot of the occlusal trauma away. You deliver vertically loaded posterior teeth, beautifully leveled arches. And sure enough, that beautiful alignment gives you your normal gingival architecture. So the opportunity to get all of this accomplished with just 3 visits is tremendous. That gets us to the point for Q&A. I'll invite Kyle to come back on there because I know he's got some questions for us to talk through and answer. I know a few things were covered during the meeting, but we have a few questions we can handle now.
Yes, thank you, Dr. Moralia, for that amazing presentation. There have been a couple questions that have come through the chat that we will answer. The first one, can we do something to aid unerupted teeth?
Yes. In fact, we now have a mixed dentition protocol. So we can work between 8 and 12. So we worked our way to a mixed dentition protocol. So if you are seeing children and or in mixed dentition where not all the permanent teeth are there, we have a beautiful expansive protocol to develop the arches out with our aligners, and it follows the same protocol. For kids, there's really no IPR. You just want to move all the teeth, but minimal to no attachments. So definitely check into our mixed dentition protocol. You'll really enjoy how the arches are set up and then accommodate the teeth erupting into the aligners.
Great, thank you. Okay, next question. Aren't a lot of the screening symptoms related to parafunction? Can we really promise that their bruxism will improve as a result of clear aligner therapy?
Oh, no dentist should promise anything. So promise is a very bad word across the board, whether it's you're doing fillings, crowns, root canals, doesn't make a difference. We're not supposed to promise anything. What you learn over time is, yep, the parafunction, the bruxing and or clenching that's going on, thanks to the malocclusion you have, when you improve your occlusion and you have a better bite, that vertically loaded better bite that has good balance, and then of course better contacts and no interferences, all of a sudden you should experience a reduction in the parafunction. So I'll give you my experience and what I see happen. The patients who are crowded, that have these terrible malocclusions, tend to have more parafunction. And in the early stages, if you ask your patients, hey, would you save the first couple of aligners for me? Because one day you're going to want to look at those. Keep the first couple of aligners. Here's why. When you wear an aligner for 2 weeks and you are a clencher or a grinder, it will show. That aligner is going to take a beating. It's going to have marks all over it. Sometimes they can even wear a little hole in it, but you will notice, yeah, that aligner was abused by the parafunction. The difference becomes at the end. When your patient wears their last couple of aligners for 2 weeks each and you look at those, you shouldn't see that same wear and tear. That aligner should look new. So the better you've made that occlusion and the more, of course, vertically loaded and balanced that bite is, the less clenching and grinding you should have. Now we'll take it one step further. When you're in the game for years turning into decades, when you deliver a clear retainer, the clear retainer is going to be worn every single night for that patient. So whoever used to be a significant bruxer and clencher, if they wore a retainer every night, it would get destroyed. When you correct that malocclusion and you have a really beautiful bite on your hands, they should be able to wear their retainer for 2 years each without a mark on it. So we have reached a limit of wearing a retainer for 2 years each. My patients routinely wear the aligners. Then when they're done, their clenching and grinding is reduced so much that they can wear a single clear retainer for 2 years without it getting destroyed. And then we graduate to another one because after 2 years, they just want a new retainer. So I give them 4 sets. We do have a retainer system. Permaform retainers are 4 sets of retainers that they can have at the end. And sure enough, wearing those, you can get your 2 years in without the destruction of the aligner. Now you know, hey, your patient's clenching and grinding less. If they're still clenching and grinding, you might not have widened and uprighted that arch enough to have solved the malocclusion. So I will do a little more work until I know the clenching and grinding is reduced. We don't promise anything, but yes, developing a better occlusion does reduce the clenching and grinding. And I don't have patients wearing through or breaking the aligners in under 1 year each, and most are wearing them to a year and a half and two now. That's a really nice pattern to wear retainers every night for almost 2 years and not have any damage to them.
Thank you so much for that. Next question is, what are the indications for using palatal ramps on Max anteriors?
Yeah, so I'm going to say it's more of a preference or a philosophy. There are those who say putting the bite ramps back there and discluding the arch makes it easier to upright the posterior teeth. And it's not my feeling. I believe the opposite. Leaving the teeth locked in makes it easier to upright the posterior teeth, because as the posterior teeth are uprighting, you can use the upper and lower to help the lagging one by having the inclines dragging along. So I'm not a fan of separating the back teeth, but they do exist as a feature. And you could think about a lot of aligner features are like a remote control for your TV. It has a zillion buttons on it. And some people like these buttons and some people like those buttons. And meanwhile, you can press and you can do a whole bunch of things, but not everybody uses all of the features in the remote control. So I don't use all of the features in the aligner system. But if you've had experience with bite ramps and it's worked well for you, then by all means, you should use them. I prefer not to use them. I find I get better expansion without them.
Great. Speaking of expansion, can you touch base on expansion and how it can help patients with sleep issues?
Yes, so it turns out it's all about the tongue space. So when we're talking about the collapse, that arch form width and inclination, all those things add up to less tongue space. Improper arch form, improper arch width, and improper inclination, teeth closer to the tongue. So think about, where can your tongue go when you bite down? When your mouth is closed and your teeth are together, your tongue only has one place to be, behind those teeth. So the closer your teeth are to your tongue, the further back your tongue is. In the sleep and breathing research, this is referred to as posterior displacement of the tongue. And if your tongue is further back, that's bad for breathing. So how do you give your tongue more space? One way is upright all the back teeth. And when you upright all the back teeth and you then procline the front teeth forward, you're spreading out the teeth away from the tongue. Now you've got more room for your tongue. So width, we're getting an increase in width. That's helpful. But remember what we talked about, when we upright the back teeth and they touch sooner, it solves the deep bite. So when you start out with a deep bite and you end up here, that's a big improvement. So you have to look at the distance between the palms, right? The deep bite, there's less room between the palms. That's less room for your tongue. When your bite is here, you get more room for your tongue. Now, this change is better being done by posterior uprighting, because that increases your VDO. Anterior intrusion does not increase your tongue space. So I'm not a fan of anterior intrusion, because you're not increasing your tongue space, solving your deep bite that way. I prefer the posterior uprighting. Now you've got the width and the vertical improved. And with all that extra space comes more room for your tongue to be forward and higher. So yeah, you're looking for more tongue space as a pathway to improve your patient's sleeping and breathing. I don't treat OSA. We're not treating OSA. You are treating malocclusion or underdeveloped jaws. When you're treating the malocclusion and you give the tongue space back, good things happen. And sure enough, those good things will translate into better sleep credentials. Whether or not you'll pull a patient out of OSA or just improve it remains to be seen. So we're going to solve your tooth and your bite position, and then the extra space your tongue has, we're going to find out how much of a difference that makes in your sleeping and breathing. And sure enough, that translates down the road into significant improvements in the sleeping and breathing quality your patients will tell you about, as well as their TMD symptoms fading away too. So lots of TMD improvements come from opening up that bite and restoring the VDO, basically releasing the lower trapped jaw.
Thank you. Next question is, what do you do when the proposal comes back with spacing left between posterior teeth?
Yeah, so the first thing I'm going to look at is the upper laterals. So it's wonderful when the patient has crowding, because when you start out with crowding, you just lose the crowding. But we do have patients who have little to no crowding, but do have collapsed arches. And when you want to spread that all out, you might get spaces. It's very understandable if they were extraction treated before, because if the premolars were extracted, you're going to have space there. But if they weren't and you have 28 teeth, the first thing to look at is the upper laterals. If they're undersized, I like to shift the space there. I don't mind adding a millimeter to undersized upper laterals. So you can put a millimeter on the side of your laterals and make that a bigger tooth with a nice bonding or veneer, and your patient has more proportion. So I'm going to look to hide it in the laterals first. But when the patient does come in completely collapsed and then has a list of like sleep breathing symptoms, we're going to talk about that space being better for them to have more tongue space. And then maybe we can put a little bonding there. So take a look and see if they have old restorations. Maybe you'll replace a filling, or maybe you'll have to upgrade to a crown somewhere. Or don't be afraid to add a little bonding. So I do plenty of composite in places to hide space. You shape it nicely, make sure they can floss beautifully. It's clean and smooth, so it's not an insult to the gum tissue. And it's easy to hide some space with a little composite. I lean more towards having the space and restoring it than not, based on the tongue space and the breathing. So I'm a big fan of having some space somewhere and then doing a little bonding.
Great. How do you handle a case that is not tracking after an additional week of wear?
Yeah, so let's say the patient wears their aligner 2 weeks and they're told wear it another week. And after the third week, when they scan again, they're told wear it a fourth week. You get an email. And when you get a notification, you'll get a notification, but it comes after having an ortho review. So because we have an orthodontic team, an orthodontic specialist behind the scenes that oversees the treatment planning, as well as approving the treatment plans before it even gets to your eyes to review and proceed, that case goes to them first. So that case goes to the orthodontic reviewer. And what they do is they choose between one of four things. One choice is move on to the next aligner. One choice is wear that an extra week. Another choice is go back one aligner. And the last choice is let's get into the office for a visit with the doctor. So there are these four choices available to us. What the orthodontic reviewer is doing is, number one, looking at the treatment from day one all the way to the stage we're at. Well, let's just say we're at number 10. They'll take a look at all the scans. They'll take a look at the scans and the tracking and see what are they looking at. Now, with that, most of the time what's going to happen is there's one sensitive spot somewhere where the AI is picking up that we need to wear it longer, but we really don't. We've accomplished the movement. So it's a very sensitive system, and it might pick up something so tiny. My experience is that the orthodontic reviewer almost always chooses move on to the next aligner. So basically, whenever I have gotten a notification that my patient has now worn it for 4 weeks, and it comes in the form of an email where you get a choice, but it does state our orthodontic reviewer believes that you should proceed with the next aligner. Do you agree, or would you like a different choice? And it's for you to choose. So I always choose, yeah, move on to the next aligner. When you move on to the next aligner, 2 weeks later, you should have a successful scan. And that has happened to me in my experience, moving on and getting a successful scan. So I've never gone backwards. I've never worn it a fifth week, and I haven't made the patient come to the office. The orthodontic reviewer has always chosen, this is really close enough to move on to the next aligner, and then you can move forward that way. So yeah, basically it's a built-in system to have someone else review it first for you before you even have to go through it all. And then you have their opinion on top of everything before you make a decision. So it's a pretty tight system.
Yeah, you talked a lot about the orthodontist there, which is a perfect segue to our next question. Is it possible to talk directly to the orthodontist planning my case so I get exactly what I want out of the treatment plan?
You can communicate with them, yes. So there is an opportunity to set up a session where you can talk with them. So we do have communication set up with the orthodontists so that you can review with them the case setups. Yes, that exists.
Great, thank you. Dr. Morali, could you go one slide ahead? We're at the hour mark, so I want to make sure everyone has a chance to scan more time for CE, but we do have more questions. If we're all open to it, we can hang on for a couple more minutes and answer a few more questions.
Yeah, sounds good.
Are there any differences in the aligner material than other brands? If so, what are the benefits?
So we're using the ZenduraFlex. And so the ZenduraFlex, same thing there. In the research of the test, ZenduraFlex performs the best. It has the lowest initial pressure on the teeth, but it maintains it the longest. So as far as the testing goes, the ZenduraFlex material is the best performing aligner material. So we use that one.
Great. Next question is, when would you choose to use clear aligners for arch expansion versus palatal expander?
Yeah, the palatal expanders, if we're in the mixed dentition, then you're thinking about, okay, how narrow is that child? Are you looking at bilateral crossbites? Are they really narrow, V-shaped, vaulted palate, combined with lots of symptoms? Cannot breathe through their nose, struggling to sleep through the night. If they have a long list of symptoms, and then you're thinking about, I'd rather get them caught up a little quicker with the breathing, I might throw the expanders in first, then switch to aligners second. If the child has more mild symptoms, the aligners are very capable at developing the arches beautifully. So it's not so much about the amount of crowding, it's about how narrow they are and whether or not they've got a list of significant symptoms. The more they're struggling to breathe and sleep well, I might jump into the expanders first. When we're talking about adults, the removable expanders for adults are very nice, but same thing. Are we looking at a unilateral or bilateral crossbite? Because the aligners struggle a little bit with the posterior crossbite. So unilateral, bilateral crossbite, I might think about a removable expander for an adult first. And then, of course, there's the sleep breathing category. The adult who's already has their OSA diagnosis, maybe has a CPAP or refused it or tried it or whatever. If they're already in that camp, then you probably want to have a little more. So I would go removable expander first, followed by the clear aligners second. So based on how narrow, posterior crossbites and or symptoms, you could lean towards maybe I want a little extra growth. So removable expander for the adult, followed by the aligners.
Thank you. Do you usually take your bite scans in maximum intercuspal position or centric relation position to help upright posterior teeth?
I love MIP. So I do MIP. My whole entire 2+ decades of clear aligner use has been in MIP.
Perfect. Thank you. A few more questions. How does the system integrate with TMJ therapy, i.e. myo-aligner?
Oh, yeah, terrific. So myo-aligner would be used first. So your patient that's got that moderate to severe TMD characteristics and or migraine headaches, now you have something that's FDA approved in the migraine and the TMD category. The myo-aligner with a TENS and or appropriate bite record can set up that patient to lose the TMD symptoms and the migraine. Once you have that patient stable, now you know where to land. The ortho is second. So the pathway with Dr. Motlaw would be getting the myo-aligner, establishing the comfort and the credentials of healthy, but now knowing, okay, where do I have to move these teeth to? Now you have an opportunity to do your ortho, because you will want a lot of expansion. You're going to want your widening and uprighting and all that stuff. And it doesn't mean the patient won't need some restorative later on, because some of these mouths that we're dealing with are heavily worn. And so the heavily worn mouth is still going to have a full restorative component, but you would love to have your position at the beginning of the case already be determined by an FDA-approved pathway for migraine and TMD solutions. Myo-aligner is a wonderful precursor to ortho. You go from myo-aligner to your aligners, and then from your aligners to your final restorative work. And then your patient is not condemned to a splint or night appliance for the rest of their life. They just wear a clear aligner retainer to bed.
Great. Okay, final question, and it's actually one that I can answer. So
Yeah.
I'll pick this one. But the person said, very informative. Is there a recording of the webinar for me to watch it again? And the answer is yes. We will send out a follow-up with a recording, which you'll get in your email.
Now, this is where I can conclude the CE portion, because we're going to go into the specifics of Candid for the next section, and then go ahead and also talk about the monitoring, which again is more specific. So if you catch a picture of that barcode, great. If not, I'm going to have it coming up towards the end where we give that back to you. So don't worry if you don't get it now, I'll give it to you one more time. All right, so now the Candid Pro aligner system. To get more specific, I want to talk about this no attachment or minimal attachment. So minimal to no attachment, because we just showed those 3 cases done without any. And that doesn't mean that we never use attachments, but I can tell you it's very minimal. And there are reasons why. So we're going to take a look at the right side of the screen, where you recognize if you're doing the aligner game, you're probably doing these now. And that's not that fun. It is not that fun to do all that, and it makes them more unsightly. But on the left side of the screen, the minimal to no attachment process begins with the model formation. How is the model formed? And when we produce our model, we do not block out any of the gingival embrasures or undercuts. So we have the full buccal gingival embrasure there to grab, and the lingual as well. So with all of those undercuts available, we're going to form our aligner into those undercuts, but then we're going to make a choice on the cut. And we are going to use a straight extended trim line. And the straight extended trim line extends 1 to 2 millimeters past the gingival zenith. And that straight cut, this is on purpose. This is intentional. These choices are intentional because when you have a straight extended trim line, it's going to maintain the strength and rigidity of that aligner for the 2 weeks you're going to use it. But also, it allows that aligner to form into the undercut and remain rigid in these areas so that you have engagement of the whole tooth. Once you have the gingival embrasure engaged on the buccal and lingual, basically you have converted the whole tooth into an attachment. With the buccal and lingual undercut engaged, your entire tooth is now an attachment. You have a almost 360 degrees around that tooth engaged fully in an undercut. And it brings us to this research where we can explain what I mean by engaging the undercut. So this is just fantastic. There's research out there on the different trim lines for aligners, and it turns out one of them outperforms all the rest of them. So we'll start at the top, and you might be familiar with this. If you're in the aligner game, you're probably using a scalloped trim line right now. The blue on top is a scalloped trim line, and we're putting 6 attachments across the front teeth. With 6 attachments across the front teeth, it takes 8.8 pounds to pull that aligner off. So it's called perpendicular pull-off force. How much retention does that aligner have? Scalloped trim line with 6 attachments, 8.8 pounds to remove. Let's go to ours. The straight extended trim line. The straight extended trim line with no attachments takes 16 pounds to remove. So you have double the retention without the attachments. If we put the 6 attachments on these front teeth here, you're almost triple. It's 22 pounds to pull it off. We don't need 22 pounds per square inch to pull off an aligner, so we rarely put attachments. Engaging the undercuts and the embrasures gives you your grip. And not only does that give you your grip, it's going to give you the better fit all the way through the gum line here. And what shows up on the right side of the screen helps to show you where the contact is. Where does your aligner actually engage or contact the tooth? It turns out the scallop trim line only has its contact in the incisal half of the tooth. So most of the contact with scalloped aligners is in the incisal half of the tooth. The gingival half of the tooth, the aligner is away from that surface and not producing any contact there. That's less control. When you look at the straight extended trim line, that is formed into all the gingival embrasures. The aligner can contact all the way at the gingival third of the tooth. Basically, the contact in the scalloped trim line is from the incisal to the gingival, from the mesial to the distal on both the buccal and the lingual. So you now have a tooth that is fully engaged by the aligners. The tooth is the attachment itself, and you have contact everywhere. So all of this adds up to better tracking. So better tracking, better retention, better fit. All of this is the straight extended trim line. Now, the straight extended trim line performed the best in all the testing, and the one in the middle is just a straight trim line that would be trimmed right exactly at the gingival zenith. The straight trim line performs right in between these two. So the worst performing aligner design is the scalloped trim line, which is why the scalloped trim line requires lots of attachments to try to make it work, because you have to get a grip on the teeth when the gingival half is not engaged. So here we have these choices to choose. So of course we use the straight extended trim line, and that gives us the opportunity to avoid a lot of attachments. So using our system automatically gives you less attachments. Now, we are a full aligner company, full aligner service company, so you can have attachments, and we do use them, but minimal attachment use is available with us. IPR, minimal attachment use is available because we, as a default, we set up an expansive protocol. So this is what we're trying to avoid, is doing these 0.3s, 0.4s, and 0.5s in just one chunk. We don't necessarily need that. If you're looking for black triangle reduction, you use a 0.1 or 0.2 somewhere, totally fine. When there are instances where a little bit of IPR helps out something, great. We're not looking to do a, let's just cut a bunch of IPR and get the front teeth straight, when we could address the arch form with an inclination and take an unhealthy occlusion to a healthy occlusion. So we try to use IPR as minimally as possible too, but we're a full service company. If you love your IPR, we're happy to put it in the computer. Pontics. We can have Pontics in our aligners so that you can do some more aesthetic solutions for your patients who are missing teeth, or you're going to replace with implants, or you're going to do some bridge work in there. So the Pontics can be in the aligners. That's nice to have. For those of you who are further into the game and you're aware of bite ramps and what they can do for separation, if you're a fan of bite ramps and you like using these, we have those available as well. So they can be used across all of the anterior teeth, not just the 2 centrals. The packaging is fascinating. And so the packaging comes and it's like getting a gift. So this box opens up, and right away on top, there's a barcode to scan. So when you open them up, your aligners are stacked and numbered, but there's a barcode to scan because that puts the app on the phone. And once the app is on the phone, there are tutorials and a very simple pathway, which is very intuitive for a patient to move into using their aligners. Once the app is on the phone, patient will get an email, download, app's in the phone, congratulations, get started. It's very simple to navigate. It's very easy for patients to do. We've got all ages from mixed dentition into the adulthood who have them and have no problems using this app. It's very simple. The kids pick it up without even telling them how to do it. So if you're in the mixed dentition or teen years, that's helpful. It has good ratings. It's got very nice ratings. So there's that. And then on the side here is the scan box. And the scan box, since you've got your phone and an app on there, your phone will attach to this scan box. The tube is a lip retractor. And when the patient puts their phone in that and uses it to hold against their mouth, they can take a scan of their teeth. And once they take a scan of their teeth, we get to track it over time, but remotely. So how does this work? They put their phone into the scan box, put the tube in their mouth, and sure enough, this is visible in the mirror. So the patient is obviously facing the mirror, and they can see with the green bar, it'll tell them what to do. Tip it up, tip it down, open, close, go left, go right. Basically, you follow the arrows. And as you follow the arrows, you're basically given a notice that you got it. Move on to the next. Let's do this way. Let's do that way. The whole scan takes 30 seconds. But meanwhile, the way this works is you take a scan on day one, you put your first aligners in, you take a scan, you've got a baseline. Then you're going to scan day 7 or 14, depending upon when you're changing your aligners. For mild cases or cases where you've got some additional ones to wear to finish up the case, you could do 7 days. But for more of the moderate and severe cases, you'll probably do a 14-day, but you select it in the app. So the doctor sets that. The doctor sets the tone saying, okay, we're going to have you change in 7 or 14 days. And you put it into the computer, so it's programmed for the patient. And then in the app, it pops up as a reminder every 7 or 14 days for them to take their scan. When they take their scan, you follow the instructions. So the patient who has good compliance will be told, congratulations, everything is perfect here. Move on to your next aligner. And then they put the next one in, and so on during this process of every 2 weeks, right? For the patient who doesn't have a good 2 weeks and they don't wear their aligner, the scan will pick up that the teeth have not followed enough, and you need to wear that 1 more week. So the patient gets told, wear your aligner 1 more week, scan again. And then they get told to move on then. So easy to follow instructions. The scans will slowly stitch together. So it starts to slowly stitch them together. So over time, you can see the progress of the teeth shifting around. And in the app, we have access to chat, phone, email support. So all of it's in there, and that takes that out of your office. If you get into the aligner game and you realize that your team up front is handling aligner phone calls all day long, a lot of that can be handled off site. So we do keep that out of your office, which is very nice. This really eliminates all of the inconvenient aligner checks that have to show up in whether you're doing 6 weeks, 8 weeks, 12 weeks, 10 weeks, whatever it is you choose. All of those visits are non-productive. So we're trying to eliminate your non-productive chair time by having the monitoring be at every 2 weeks. And then the patient is instructed to move forward as the monitoring shows that they're good. And then on the doctor end of it, you have this in your portal. So when you open up your portal and you see your patient list, you can see how they're tracking right along. Every scan they take is uploaded. And then the bar is the aligner count right across. 1, 2, 3, 4, 5, 6, 7. Green circle, they did a beautiful job those 2 weeks, move on to the next one. Red box, scan it a week later. So here they had to go and wear an aligner an extra week. Maybe they forgot it somewhere or didn't wear it to bed or didn't wear it to work one day. So all of a sudden you have this incredible oversight. Basically, it's the most amount of oversight you could possibly have, but also the least amount of chair time. So you have this available to you. You don't have to check it every 2 weeks. You don't have to go peek in here. The only time I really take a look is when I get a notification. If the patient had to wear it an extra week, no, the patient got a notification, you get a notification. We advise your patient to wear it 1 more week before scanning. So then you have an idea who's moving along well, and you take a peek at this as you see that happening. And then when you know they moved on, you're good. Okay, they caught it back up. So this is really terrific that you have access to seeing these scans. You have the most amount of monitoring with the least amount of chair time. All of this adds up to eliminating the aligner check column, because the general dentist who's fixing teeth all day long has a full restorative schedule. Then you've got hygiene patients to check. What you don't need is a full aligner check column. And as you get involved in volume, you'll recognize that if you're already in that game, you're checking a lot of aligners along the way, all of that could disappear. Now, how does it work out if we do a little study of 100 patients each way? Here it is. So this is fascinating because you get a control group where we're doing conventional treatment with aligners coming in for regular visits. And the experimental group is basically going to give the aligners at the first step and then wait until the last aligner to come back for a check. So no chair time. The office appointments for the average aligner, the average patient in this 100 group was 7.2 appointments, and here 2.1, because we were trying to do 2 only, but 2.1 because there were a couple of refinements. Your team gets utilized at about 10.5 hours to treat these 100 patients. Each case needs 10 hours of treatment over those visits, over this time frame, whereas in this group, it gets cut in half. We're about 4 hours of treatment time total here. The refinement rate for this 100 group, 91%. So 91 out of 100 are going to get refinements. That extends your treatment time a little longer. Your average treatment time will go up with more refinements. The control group here for the 100 that were treated in the 2 visits to start and finish, only 14% got a refinement. 86% finished after the first set of aligners, and that takes your treatment down, but your average treatment time is lower. So the difference is significant. These are significant numbers. And again, the control group is your conventional treatment of your aligner patients with your everything, the attachments, the visiting the office. And here comes the straight scalloped trim line. No attachments, no IPR, doing 2 visits start to finish. And sure enough, having much less chair time equals profitability for you. So that's our pathway to do more profitability.
With that, thank you everyone for joining. Thank you, Dr. Moralia, for an amazing presentation tonight on your experience with clear aligners.
My pleasure. Thank you. Thanks for hosting.
Of course. Thanks, everyone. Have a great night.
Good night, everybody.